Sepsis is defined as a dysregulated host response to an infection, leading to organ dysfunction. So, what exactly is a dysregulated host response? For that, we have to understand what is a normal or a regulated host response to an infection. So, like if you have an infection in the lungs and it is controlled by the body's immune system, either on its own or by the help of antibiotics, then it becomes a regulated or a normal host response. When there is an excessive immune response, which leads to spilling over of the immune response into the bloodstream and other organs because of hypersecretion of cytokines, which are signaling molecules, and this is known as sepsis. And it leads to organ damage beyond the site where the original infection was. So the word sepsis is derived from the Greek word sapien, meaning to rot. And the etiology is classically gram-negative bacteria, also gram-positive bacteria, viruses, fungi, and even parasites. Even infections like malaria can result in sepsis. The cytokines which are central to this is TNF, that is tumor necrosis factor, and interleukin-1, though there are a variety of cytokines. So it classically presents with fever. Fever occurs because of interleukin-1 stimulating the thermostat in the hypothalamus. Tachycardia occurs again because of the cytokines stimulating the sinus node and also because there is shock at times. Tachycardia and tachypnea are very common, and tachypnea occurs because the cytokines stimulate the respiratory center in the brain because the lungs are often involved and are hypoxemic, and sometimes there is metabolic acidosis, so the lungs try to uh, compensate for this metabolic acidosis by washing out the CO2. Oliguria is sometimes seen, which is due to cytokines injuring the kidneys or because of hypotension, and altered in sodium is also seen at times because of cytokines hitting the brain and causing dysfunction. Now, a key feature of sepsis in some patients is septic shock, which is the severe form of sepsis. This shock is classically known as distributive shock and is also called warm shock, as opposed to the cold shock seen in cardiogenic shock or hypovolemic shock or hemorrhagic shock. So why is it warm? One, because many patients have fever, though all patients do not have fever. Some patients may have a normal temperature. Some patients to the tune of 10% are actually hypothermic. So if there is fever, then it becomes warm. The extremities become warm. And if the cardiac output is high, which is generally the case, then there is increased blood flowing through the peripheries. And that is why there is warm extremities. Also, it is to be known that all patients do not have a warm shock. Some patients have a cold stage also, which may be manifested initially or at any stage. That is due to a decreased cardiac output. Now, an important way to holistically understand sepsis is the acronym PIRO. P stands for predisposing factors. I stands for infections. So what is predisposing factor? That is whether the patient is young or old, whether he is immunosuppressed, whether he has severe diabetes, chronic kidney disease, and so on and so forth. Infection means what kind of an infection, whether a bacterial, viral, what is the source of infection, lungs or urinary tract, and so on, and how severe is the infection. So infection can come from anywhere. Lungs is the commonest source, and urinary tract is the second commonest source. It can come from the bones, meninges, anywhere. And also lines and tubes and catheters are also very important sources of infection that should not be forgotten. R stands for response of the host, which means how severe or what kind of a response the host is manifesting. Because, like I told you in the definition, sepsis is a dysregulated host response, and this varies. And now a lot of work is being done in classifying the sepsis into different subtypes, which is known as phenotypes on the basis of the response of the host. Then O, organ failure, which means how many organs are involved, how many organs are failing, and what is the severity of failure. And this can be quantified in terms of a SOFA score, SOFA, which helps in giving the prognosis. Now, organ failure in sepsis, you have ARDS, acute respiratory distress syndrome, which has a new definition, acute kidney injury, shock and cardiomyopathy, encephalopathy, disseminated intravascular coagulation, and septic or ischemic hepatitis. So, ARDS, classically it was defined as the onset of acute respiratory failure with a PF ratio of less than 300 on a PEEP of more than 5 on the ventilator or NIV within 1 week of onset of sepsis. And the bilateral infiltrates should not be attributable to pulmonary edema mainly or to any other kind of X-ray pathology like effusions or atelectasis or nodules. So now some changes have occurred in the new definition. First of all, PEEP is not necessary because some of the patients are on high flow nasal cannula. Secondly, instead of PF ratio, one can also use the SF ratio, which is the saturation by FiO2 ratio. And if it is less than 315, it is considered ARDS. That is equivalent to PF ratio of 300. Similarly, ultrasound can now be used to make the diagnosis. If you see B lines or consolidations on ultrasound, it is acceptable, just like initially it was X-ray and CT. Now even ultrasound is included. And finally, in resource-limited ICUs where there are limited tools and monitoring devices, if the clinician thinks that the patient has acute respiratory failure and the SF ratio is less than 315, that is enough to define it as a ARDS. Now moving on to acute kidney injury. So why do you get acute kidney injury? You get it because one, there can be hypotension, and even if there is no hypotension, it can occur because the cytokines go and cause impairment in the microcirculation of the kidney, and also because the cytokines filter through the tubules and cause damage to the tubules and interstitium. Now moving on to shock and cardiomyopathy. Shock we will discuss in the end. Cardiomyopathy. So cardiomyopathy, which is known as septic cardiomyopathy, is typically characterized by a LV ejection fraction of less than 40%. However, even diastolic function can occur and even the right ventricle can be involved. And when you get a depressed ejection fraction, the cardiac output falls, and this typically leads to a cold stage of septic shock, which I had alluded to earlier. Now, encephalopathy manifests as obtundation, lethargy, focal signs and seizures are highly unusual. Disseminated intravascular coagulation occurs because of activation of the procoagulant pathway and downregulation of the anticoagulant and the fibrinolytic pathway. So this leads to formation of a lot of clots, micro as well as macro thrombi, and this consumption of the clotting factors. So initially there is clotting, and after that, because there is consumption of clotting factors, there is bleeding tendency. So you get both clotting as well as bleeding, or variable manifestations. Septic hepatitis is classically what occurs in the liver, and this is characterized by increase in conjugated bilirubin along with plus minus alkaline phosphatase. And this is because of sluggish biliary flow, what is called intrahepatic cholestasis. And sometimes the cytokines directly injure the hepatocytes, which leads to elevation of OTPT. Septic hepatitis does not lead to acute liver failure. However, the bilirubin levels can go to even 30, 40, and sometimes the bilirubin can be unconjugated also. As far as ischemic hepatitis is concerned, it is not specific to septic shock or sepsis, but it can occur in any condition in which there is acute hypotension. So this is characterized by 20-fold increase in SGOT, SGPT, which occurs rapidly over a period of 24 hours. And if you restore the blood pressure, it also resolves quickly. However, this form can actually lead to acute liver failure also. So this is not really seen commonly in sepsis. Now, coming to the labs and diagnosis, there are labs which are directed specifically to sepsis and there are routine labs. So in routine labs, you have LFT, KFT, coagulation profile, ABG, chest X-ray, ultrasound, abdomen, and echo. X-ray and ultrasound abdomen are especially important because they help you in picking up the source of infection, and further imaging may be required as directed by the suspected site of infection. Now, as far as labs directed for sepsis are concerned, CBC is very important because the TLC is very important. Neutrophilia is a prominent feature. However, some patients may have a normal WBC count, that is to be known, and some patients may be neutropenic. Procalcitonin, which was earlier thought to be diagnostic, is not thought to be so now, and the use of procalcitonin is to stop the antibiotics when it reaches 80% of its initial value, along with clinical improvement. The other way it is used now is you can follow trends in procalcitonin. As the patient starts improving, daily the procalcitonin will fall. So if there is a sudden jump in procalcitonin, you know that another event like a fresh infection or pulmonary embolism or something like that has happened. CRP is just like procalcitonin, but it is less accurate slightly, though it is much easily available and cheaper. Lactate is very useful in septic shock. It is almost always elevated in septic shock. Only 10% of the patients don't have lactate elevated in septic shock. And these patients have a better prognosis. Patients whose lactate is elevated in septic shock have a bad prognosis. Higher the lactate, worse the prognosis. And if the lactate starts clearing at 8 hours, that is, if it has cleared remarkably at 8 hours, these patients have a much better prognosis than those whose lactate fails to clear at 8 hours with your therapy. Sometimes lactate can be elevated even without septic shock. Lactate rises because of tissue hypoperfusion mainly, though there are other reasons also. Then very important is blood culture and urine culture and culture from any site wherever you think the infection is present. So two sets of blood cultures have to be sent, one set of anaerobic and one set of anaerobic. And this has to be taken from two different sites, and at least 10 ml has to go in each bottle. Apart from this, it is to be realized that blood culture should go before the antibiotics, otherwise the pickup of the blood cultures goes down. Now, very important is PCR multiplex. So this is an upcoming technology and is now being widely used. It can be applied directly to the blood, which is the best way, or it can be applied once the blood culture is becoming positive. It gives a report within 6 hours, including the sensitivity, and it has a accuracy as far as pickup goes to more than 90%, while blood cultures are positive in only 30%. The only thing is, it is uh, much more expensive, and there are different technologies which do PCR multiplex. So and they are not all well standardized. So you have to choose the right panel for PCR per multiplex. Treatment mainstay is antibiotics because it is caused by an infection. And if it is viral or fungal, then you have to choose the appropriate antimicrobial. Source control means that you have to clear the surgical site of infection. That is very important. If there is a surgical source, then unless you clear the surgical source, it will not resolve. As far as antibiotics are concerned, there are two main principles. One, you have to see the site of infection, whether it's in the lungs or whether it's the abdomen, because the antibiotics will vary. Second, you have to see what kind of organisms come to your ICU, what is their sensitivity and what type. So the antibiotics have to be decided according to these two principles, and you have to give initially broad spectrum antibiotics, at least two for gram negative. And if you are thinking gram positive, then one for gram positive. And once the culture, if it is positive, or if your PCR is positive, then you tailor it to one single antibiotic, which is the best. It is very important to do this de-escalation because this actually improves the outcome. Then if the patient has respiratory failure, it is very important to give supplemental oxygen. If the PF ratio is less than 300, then you have to apply mechanical or non-invasive ventilation. Initially, we try non-invasive ventilation with NIV or high flow nasal cannula. But if the patient is deteriorating on this, or if initially the PF ratio is less than 100, then one has to institute mechanical ventilation. Dialysis is very important in those with acute kidney injury. Initially, patients with acute kidney injury are managed conservatively. However, if there are compelling indications like hyperkalemia, fluid overload, uremic encephalopathy, uremic pericarditis, metabolic acidosis, then one has to go for dialysis. Dialysis is also done optionally if the urea is crossing 150 to 200 milligram per deciliter. So dialysis is either in the form of CRT, which is continuous renal replacement therapy, or intermittent hemodialysis, HD. The difference is in hemodialysis, the blood pressure can drop, so you don't do it if the blood pressure is low. If the blood pressure is low, that is the patient is unstable, then one goes for CRT because it is much more smoother as it is done over 24 hours continuously as opposed to intermittent hemodialysis, which is done over a session of 4 hours or so. CRT is also preferred in acute liver failure and in patients with increased intracranial tension because this prevents osmotic fluxes and fluctuations in the ICT. A very important part is nutrition. Nutrition should ideally be given enterally, and if you cannot give enterally, then you have to go for parenteral. And if the patient is bleeding, then one has to supplement with plasma and blood products. If the patient is not bleeding, we do not correct deranged parameters except if the platelet count is less than 20,000 when we supplement with platelet transfusions. So now coming to the treatment of septic shock. So before we come to the actual treatment, we have to understand what happens in septic shock. So blood pressure is less than 90 systolic. Blood pressure is the product of cardiac output and systemic vascular resistance. So systemic vascular resistance depends on the state of the peripheral vasculature, how much vasodilatation or vasoconstriction is present. In septic shock, there is gross vasodilatation of the peripheral vessels. So the SVR is low. So cardiac output into SVR becomes low. Cardiac output is initially high, but gradually it starts dropping. The product of cardiac output and SVR is low, so blood pressure is low. So what are the principles of treatment? So first treatment is ventilation. You have to ventilate the patients mechanically because the lungs are working overtime in patients of septic shock as they have to provide excess oxygen which is deficient in the body. Secondly, they have to counter the acidosis. So by giving mechanical ventilation, one gives rest to the muscles. Otherwise, the muscles will go into fatigue and your CO2 will start rising. Then we have to give IV fluids. And third, we have to take care of the blood pressure with vasopressors and sometimes inotropes. Now, as far as IV fluids are concerned, what are the IV fluids and why do we need them? So IV fluids are needed because the other aspect of the physiology, apart from the vasodilatation, is continuous leakage of fluids from the blood vessels because of damage to the endothelium by cytokines. So there are two things happening. One, fluid is leaking out. Secondly, there is vasodilatation. So by giving IV fluids, we fill up the intravascular volume, that is the blood vessels, and by giving vasoconstrictors, we cause vasoconstriction of the dilated blood vessels. So that, in a sense, is the physiology and of the treatment of septic shock. So what kind of fluids do we have? We have normal saline, we have ringal lactate, we have plasma light, and we have colloid 5% albumin. So what are the advantages and disadvantages? Normal saline has a lot of chloride. It is much more hyperchloremic than plasma. So if you give a lot of normal saline, then chloride levels can go high, and if chloride level goes above normal, then it can lead to vasoconstriction in the afferent arteriole in the kidney, which can lead to acute kidney injury. So that is the downside of a lot of normal saline. Then ringal lactate. So ringal lactate has some potassium and lactate. So if there is hyperkalemia, you do not want to give too much ringal lactate as potassium levels can go up. Secondly, it has lactate. So, one has to monitor lactate levels in septic shock as they are elevated, and they help you in guiding therapy and telling the prognosis. So the lactate in ringal lactate can interfere with serum lactate measurement. So again, you do not want to use too much ringal lactate. Plasma light is the fluid which is most close to the human plasma. However, it is significantly expensive. And 5% albumin is a colloid. The advantage is that if you use colloid, then you have to use less amount of fluids. But more importantly, albumin acts against the toxic molecules which are secreted in septic shock and is supposed to have a beneficial role as a drug. So this is about the fluids. Then coming to the vasopressors, those which are used to constrict the peripheral vasculature. The vasopressor of choice is noradrenaline. Noradrenaline acts through its alpha 1 receptors on the arteries and the veins, thereby constricting the arteries, and by squeezing the veins, and the blood is squeezed from the veins into the circulation. By virtue of its beta 1 action on the heart, it also increases the contractility. The side effects are that it can throw the patient into tachyarrhythmias because they already have tachycardia and they have a beta 1 action, so patient can go into atrial fibrillation. Second, they also have an effect on the immune system. They cause immune downregulation. Then the second vasopressor is vasopressin. Vasopressin acts through its V1 receptors on the vessels. However, it is a very strong vasoconstrictor and can cause digital ischemia and sometimes mesenteric and coronary ischemia. It should not be used if the patient is not volume repleted, because there it can actually cause a decrease in cardiac output if the patient is not volume replete. Also, it should be used very carefully in coronary artery disease patients because it causes coronary constriction. Then the third vasopressor after noradrenaline and vasopressin that is used is epinephrine. Sorry, epinephrine. Epinephrine, actually the problem is that it does not add much to the vasopressin effect because it also acts through alpha and beta receptors. Uh, at low doses, at less than 10 to 15 mics per minute, epinephrine has predominantly beta 1 and beta 2 action, so it does not actually increase the blood pressure, though it increases the cardiac output. However, at doses greater than 10 to 15, it also has a significant alpha action and increases the blood pressure. The downside of epinephrine is that it can cause increase in lactate levels, it can lead to mesenteric ischemia, and it acts on the cells via its beta 1 and beta 2 receptors to actually potentiate various cellular reactions. The fourth drug, which is a new drug, is angiotensin 2, which is not easily available yet and is expensive currently. It acts through angiotensin receptors in the blood vessels, causing vasoconstriction and elevates the blood pressure. So these are the four vasopressors in order of choice. And Dopamine is sometimes used to increase the cardiac output if the EF is low. Epinephrine can also be used to increase the cardiac output if the EF is low. As far as the doses are concerned, norepinephrine is started as 1 microgram per minute and it is taken up to 15 mics per minute titrated to blood pressure, and at that point, somewhere at that point, vasopressin 0.04 units per minute is added to norepinephrine. There is no upper dose of norepinephrine. One can go on increasing norepinephrine as long as one is getting its vasopressive effect. As far as epinephrine is concerned, again there is no upper limit, and it is started just like norepinephrine at 1 microgram per minute. But I told you about its alpha and beta action, so that has to be taken into account. Now, how do you actually go about it? So you start actually IV fluids initially, and for IV fluids, you give a bolus of 15 ml per kg body weight. So, some of the literature says 30 ml per kg in all patients. That is not true. Actually, you have to give 15 ml per kg as a standard bolus in all. In CKD and CLD patients, you have to give a slower bolus and a lesser amount because they don't tolerate fluids that much. So 15 ml per kg in a 80 kg man will come to something like 1.25 liter bolus. That is given fast, and normally you have to put a central line because you have to give multiple infusions including vasopressors, and ideally arterial line should also be in place. So once you have given this bolus, you start with normal saline, and then you also start vasopressors in the form of norepinephrine, 1 microgram per minute onwards, and you try to reach a target blood pressure of mean arterial pressure 65. That is your target. In hypertensive patients, you can target 80 to 85 because this results in better outcomes as far as the kidney is concerned. So once you have your fluid bolus going, your norepinephrine going, you see your blood pressure. You want to reach the blood pressure target as soon as possible. That is why you have to start norepinephrine also and not wait for the fluid to act. So if you reach the target blood pressure of 65 with this, well and good, you can put the patient on maintenance fluids. But however, if the patient is not achieving the target blood pressure, you have to give more fluids by checking for fluid responsiveness. Because after giving the initial fluids, it has been seen that only 50% of the patients are responsive to further fluids. Because when you are given around 1.5 liters, you have filled up the heart, and by giving more fluids, the cardiac output may not improve. Therefore, you have to check for fluid responsiveness. How do you do that? So simply you can see the CVP. If the CVP is less than 6 on the ventilator, the patient will respond by increasing the cardiac output if you give fluids. You can also see the IVC. IVC can be seen on the ventilator. It has less accuracy, but you can still see it. The most precise way is to do the passive leg raise test, or you can see the pulse pressure variation. So these are some of the ways to look at fluid responsiveness. So if the patient is fluid responsive, you give another bolus of 500 ml normal saline. You can also use some ringer lactate, and some normal saline ringer lactate can be alternated. And plasma can also be used looking at the principles I told you in the beginning. So you have given more bolus and you can increase the vasopressor dose. If you have reached 15 microgram of noradrenaline, then you have to add vasopressin at this point in time. You can actually add initially also. So that is not a very sacrosanct. And you similarly, you go on checking for fluid responsiveness and giving fluids and titrating the vasopressor dose. If you reach the blood pressure target 65 MAP, then it's okay. After that, you put maintenance dose of 100 ml normal saline. And then you watch the blood pressure and taper the vasopressors. If the vasopressors are being tapered, there is no strict way of tapering vasopressors. Looking at the physiology of the patient and the properties of the vasopressors, you taper the vasopressors. And if the third vasopressor is required, you add epinephrine. and you can add angiotensin 2 also if it is available. As far as the dopamine is concerned, it is used only if the ejection fraction is less than 40% and the patient is having evidence of low cardiac output. Where do you use albumin? So albumin is used initially itself if you can give it because it is expensive, and you give 250 ml 5% over a couple of hours, and you can repeat it as long if the albumin is more than 3, then there is no point in giving any albumin. As long as it's 3 gram per deciliter, it's okay. So that was in a nutshell the treatment of septic shock. Now coming to pathogenesis, which is a very complex area, and I will try to explain this to you in 5 minutes. So this is a snapshot of the area where the infection is occurring, but this process is occurring throughout the body in different organs. And if you look at this, this is the capillary, this is the in blue the interstitium, and this is the cell. So if you come here, this is just follow my pointer. I will walk you through this. This is a pathogen gram-negative bacilli. They have this toxin which is called endotoxin in the cell wall, and this is known as PAM, pathogen associated molecular protein. And these are highly conserved proteins in nature. They react with the TLR, which is toll-like receptor on the macrophage. So the interaction between this leads to intracellular signaling, which leads to activation of the genes involved in immunity. They get activated and they release inflammatory mediators, which are mainly cytokines. A variety of cytokines are released. The most important are TNF, that is tumor necrosis factor, and interleukin 1. Apart from this, there's interleukin 6, interleukin 12, interleukin 18, interferon gamma, and many other cytokines. These cytokines are signaling molecules. They themselves do not cause damage, but they lead to activation of the immune and the inflammatory pathways, such as activation of the lymphocytes, the complement pathways, and the kinin system. And various molecules are then secreted, and some very important ones are prostaglandins and leukotrienes, especially prostaglandin E2 and leukotriene 4, and also proteases and various kinds of kinins. So these are some of the molecules which are secreted. And there is inflammation going on because of all this that is happening. This inflammation damages the tissues, which leads to DAMPs. So what is DAMPs? DAMPs is damage associated molecular protein, just like PAMPs, slightly different in structure. These are again recognized by macrophages and leads to amplification of the immune system regulation. Now, once this is occurring, there is increased expression of tissue factor on the macrophages and other cells. Expression of this tissue factor leads to activation of the coagulation pathway. Simultaneously, there is inhibition of fibrinolysis and there is downregulation of the anticoagulant pathway. Thereby, thrombi are generated in the microcirculation. Now you see here what is happening is that neutrophils are moving across the capillaries in what is called diapedesis because of activated endothelium with expression of ICAM and VCAM. And there you can see the leukocyte is getting activated initially itself by the cytokines and the PAMs also, which they recognize. The leukocytes release reactive oxygen species, ROS, and nuclear extracellular traps, what are called NETs or nets. And this not only kills the bacteria, but it also damages the tissue because there is hyperstimulation. Now, all this inflammation and damage is occurring. At the same time, there is hypotension because of hypovolemia as the fluid is leaking out due to endothelial damage. And there is vasodilatation. Why vasodilatation occurs? Because of nitric oxide, which is secreted in excess by the endothelial cells of the capillaries. So you have hypotension, you have thrombi formation, so thereby there is altered microcircular flow, which is very sluggish, and fluid has leaked out into the interstitium, thereby increasing the O2 diffusion distance. So because of this, there is also decreased delivery of oxygen to the cells. And as there is decreased tissue oxygenation, the cells are not getting enough oxygen. There is mitochondrial dysfunction occurring because of this, as well as because of the various cytokines. So there is decreased ATP production, because for Krebs cycle to occur, we know that we need enough oxygen. So ATP production is decreased, and simultaneously there is increased lactate production because of anaerobic glycolysis. Hydrogen production is also increased in simultaneous reactions, and the acidosis occurs, as well as hyperlactatemia. It is to be noted that lactate is produced as lactate and not lactic acid. However, for each molecule of lactate produced, a hydrogen ion is produced. So all this inflammation, the dysregulation of the immune system, the hypoxia leads to organ damage, and unless it is countered by antibiotics and supportive measures, the patient actually succumbs.